Hello, ladies and gentlemen. No matter what time zone you're joining us from, good day and a very warm welcome to this Bayer LinkedIn live event in connection with Breast Cancer Awareness Month. I'm Melinda Crane, and it is my great honor to accompany you as moderator today. Our title is Advancing Outcomes for Breast Cancer Patients. In breast cancer, as elsewhere, we've seen groundbreaking advances in recent years. Innovations in research, imaging, surgery, and clinical trials are giving women many more options, as well as better chances of overcoming the disease. And this is especially true for cancers that are detected early. And yet, breast cancer remains the most common cancer, among women worldwide. Since 2008, so sorry. Since 2008, worldwide breast cancer incidence has increased by more than 20%. Mortality has increased by 14%. We can do better. Better on detection, because it's not one size fits all. Screening procedures that work well for some women are less accurate than for others, depending on individual risk factors such as breast density. Many of us aren't even aware that we have dense breasts, much less what that means in terms of cancer risk and optimal screening options. There are a lot more options out there than many of us realize, but it takes awareness to make an informed choice. We can also do better when it comes to treatment. Here too, many women remain in the dark about options that can help them mitigate unpleasant side effects of breast cancer therapy. Side effects like vasomotor symptoms. In laywoman's language, those are menopausal symptoms that can prove so burdensome that they cause some women to break off treatment. It is crucial that we speak openly with our healthcare providers and with each other, ladies. And that is what today is all about. What do we need to do? What do we need to know to make informed decisions in consultation with our healthcare professionals about the screening and the treatment options that are best suited to our needs? That's our key question today, and we have an outstanding lineup of speakers to address it. I'll introduce them in just a moment, but let me just say beforehand that although we are meeting virtually, we're very eager to make our discussion as lively and interactive as possible. You, dear audience, can share your questions and your brief comments using the chat function on this live stream. After each of our speakers shares her perspective and his perspective, I will pass on your questions to the panel. Before we start, I'd just like to remind everyone that this is an awareness-raising event that is not product-related. So we are not going to be sharing questions or statements about specific brands of medications or screening processes. Also, dear speakers, we have a very compact window of time, as you know, so please do keep your initial remarks within the agreed time of 3 to 4 minutes maximum. And now, let's get started. Our first speaker received a breast cancer diagnosis in 2016. Since then, she co-founded Breast Density Matters UK and became European Education Coordinator for DenseBreast-info, Inc. We hear now about her journey from diagnosis and treatment to patient advocacy. It is a great pleasure to hand over to Cheryl Cruwys.
Thank you. Good afternoon, everybody. What I would like to do is I'd like to share my dense breast journey with you now. I'm from London, and in 2013 I moved to France. I was invited to attend my first routine mammogram appointment, which I did. The radiologist said it was normal, my result. No abnormalities seemed to be found, apparently a clear mammogram, but a decision was made to carry out an ultrasound as there was an area of dense tissue. It was only later that I discovered that dense tissue is normal and it's common, glandular tissue, but we now know that it obscures and hides cancers on mammograms. So the ultrasound showed an area of concern that was not shown on the mammogram, and a biopsy confirmed an 8mm invasive tumour, grade 1. So moving on to treatment, I had a lumpectomy to remove the tumour, which was node negative. Several weeks of radiotherapy. I did not need a mastectomy and, of course, not reconstructive surgery, nor in my case, I didn't need chemotherapy. The French breast screening protocols and guidelines contributed to my early diagnosis when my cancer was found early and small because of supplemental screening on dense breast tissue. So a few days after my lumpectomy, I decided to form Breast Density Matters UK, a patient advocacy, as I recognised that there was a real gap in knowledge on this topic, and there really was awareness was needed. So the aim was to educate women initially, then the general public, and as it developed, also healthcare professionals. So that really in brief is my story, but I just want to touch very, very quickly on some challenges and experiences by individuals going through breast cancer and treatment. There are so many. It's probably too many to go into detail now. So I'm literally just going to touch on the physical side. When you are diagnosed with breast cancer, your world is turned upside down. The first thing you think of is physical. What is going to happen to my body? What is going to change? The second thing, probably, or coupled with that, twinned with that, is emotional. You've then got to tackle and speak to your family, your friends. It's not a nice conversation to have, okay? Psychologically, you're thinking about it. It's always in your head. You go to bed, it's in your head. You wake up, it's in your head. It continues to be a real concern. You don't know what's going to happen to you. And for some people, financially, if they're in the type of work whereby if they don't work, they have to work to be paid. If they don't do that, then financial situations will really, really impact them. So just to sort of finalise and just to summarise very quickly, I would say not just in Breast Cancer Awareness Month, but this should be a constant. Why increased awareness is important. If a woman possesses education on a topic of breast cancer, they can have a conversation with their healthcare professionals. They can make informed choices and decisions, and ultimately, awareness can potentially lead to earlier diagnosis and better health outcomes. My take-home message is very, very simple, that knowledge is power. And that brings me to a close. Back to Melinda.
Thank you so much, Cheryl, for that very emphatic reminder about the importance of awareness. And we will come back to that a little bit later on. So let us now talk a little bit more about both early detection and supplemental screening. And we have two experts to share some perspectives with us. We begin with Dr. Hassan Khater. He is formerly head of Medical Affairs Egypt and Levant for Pharmaceuticals, and is now Senior Medical and Clinical Affairs Physician at Bayer Radiology. So over to you, Hassan, please. You have the floor.
Thank you, Melinda. I mean, as just mentioned from Cheryl right now, early diagnosis is a key for breast cancer. And we know that the gold standard for screening is mammography. So women are recalled to do a mammography screening, and this is something very important, that they should do the mammography examination. And mammography is according to the country. Sometimes it's done every 2 years or every 3 years, and sometimes it's also every 1 year. So mammography is a gold standard for early detection. And in some institutes also they used another modality, which is the tomosynthesis, but mostly we use mammography. But as also Cheryl mentioned, understanding the risk or the patients or the women is very important, because women are not the same, are different, sometimes with risk factors or even sometimes with breast density. And here comes the option of having a supplemental imaging modality or another imaging modality which would help in the early detection. And early detection is very important because when you detect cancers early or lesions early, the pathway is completely different when you detect in a delayed stage. It's completely different, and the impact is completely different. So supplemental imaging modality for women, sometimes we find women who have like a high risk, like genetic risk, so genetic mutations like BRCA1, BRCA2, or even sometimes women with average risk, but with something special like breast density, which also was mentioned by Cheryl right now. So having a denser breast tissue, which would lead to having a more the need to a more sensitive imaging modality. So even with mammography, sometimes mammography is not enough. And here you would need a supplemental imaging. And supplemental imaging, there was the DENSE study, which was published in 2019, referring to the MRI as supplemental imaging for women with extremely dense breast, and showed how can you detect more interval cancer for these women. So relying and verifying the fact that supplemental imaging for these women is really needed. So
Thank
the
you
message, understand the risk.
Yeah,
Very important.
please, your message, go on.
So my message is, first, we have to, if women are asked to do a mammography, we have to do the mammography. This is very important, number one. And number two, understanding the risk. So if there are women with special risk genetic mutation having an average risk, even with extremely dense breasts, there should be a discussion about having a supplemental imaging for this woman. The purpose is early detection.
Thank you so much. So clearly, advances in screening technology and diagnosis do have exciting potential to improve outcomes for women, those with dense breast tissue and others as well, especially conditions that make it hard to detect cancer early on, because as we just heard, early detection is key. So here to tell us more about the technology behind these advances is an expert on medical imaging. She's Global Scientific Marketing Manager in MRI Oncology at Siemens Healthineers, and she's responsible for the company's MRI Oncology Solution Strategy. It's a great pleasure to hand over to Dr. Elisa Roccia.
Thank you very much, Melinda. So we just heard how in breast cancer screening, sometimes it is not enough to have a mammography. So we might need some supplemental screening. And I'm here today to talk in particular about MRI, magnetic resonance imaging, and what it can do in this scenario. So starting from the very beginning, you might wonder what MRI even is. You might know it as that big noisy tunnel. The examination is not performed standing as with the standard mammography, but lying on a table. You might get an injection of a contrast media in your arm, which is needed to better visualize potential abnormality in the tissue. I know that also from experience that some people might be afraid of this examination, and that's why I would like to say a few things. So first of all, MRI does not expose to any harmful radiation, so it is a safe diagnostic procedure. Then the breast is not compressed, unlike, this is typically a source of discomfort on mammography. And you might also have heard that MRI is a very long examination, that it can take even 1 hour. Well, rest reassured that this is not the case anymore. An MRI examination can take 10 minutes or even less. So now let's see why MR is such a powerful imaging technique and what we can really see with MR. So first of all, the challenge that we have is to find a small abnormality in a breast tissue that is very dense. And we said that this might not always be possible on mammography. You can kind of think of it like looking for a snowflake in a snowstorm. Well, this is not a problem anymore in MRI because these lesions kind of light up on even if the tissue is very dense. And let's see why this is possible. With MR, you can see both the anatomy and the function of the tissue. And with the anatomy, you basically see the overall structure. But with the function, you can really see how the tissue behaves. And this is important because abnormality behaves differently from the normal healthy tissue. And so we can basically capture these differences using MR, also thanks to the contrast agent that is injected. And so the message I would like to bring now to the audience is that even though mammography remains the main screening modality for breast cancer, MRI could really be a game changer in certain circumstances. It could really make the difference. And at Siemens Healthineers, a provider of the technology itself, we want to really facilitate and support this trend. So concretely, what we can do and what we are doing is to work together with radiologists and partners to make the examination shorter. And this, what basically means for the patients and for the women, is that they would have to spend less time inside the scanner. But then we also strive to optimize the overall experience, so we can minimize the anxiety and perform the best examination possible. But also promoting education on that technology. And that's also why I'm so happy to be here today with you to talk about MRI and this technology, because I really believe that it's important for all of us to know what's happening in breast cancer screening and to be aware of the options that we have, so we can really make an informed decision about our own health.
Thank you so much. And clearly, women do have a lot more choices than many of us realize. And interestingly enough, that goes for treatment as well as screening. So let's shift focus now to drill deeper on some burdensome symptoms, namely the vasomotoric side effects, equivalent to menopause, that some women experience when they are undergoing treatment for breast cancer. We're going to hear first from Dr. Cecilia Caetano. She is a gynecologist with extensive clinical experience at Portugal's Coimbra University Hospital. She's now head of medical affairs, women's healthcare at Bayer Pharmaceuticals, committed to breaking the taboos that keep many of us from talking openly about menopause. Over to you, Cecilia.
Thank you so much, Melinda, and happy to have this opportunity to continue to break taboos now in the area of breast cancer, which is so relevant. So indeed, Bayer, as a leader in women's health, is committed to continue to advance women's health in multiple stages, from menarche to menopause. And we really aim to address unmet medical needs, broadening treatment choices for women, for their physicians, and we have a current focus on menopause management. And when it comes to menopausal symptoms, as you were mentioning, breast cancer patients are a very specific group with extreme unmet need, since impact is very high, and there are currently no approved treatments for these patients. So I would like to zoom a bit into why this is relevant. So we know that breast cancer is the most frequent cancer in women. Globally, in 2020, we had around 2.3 million of new cases. And the big majority of breast cancers, almost 70%, are what we call hormone receptor positive, meaning that the cells have receptors for hormones like estrogen, will then contribute for the growth of the tumor. So these patients with hormone-positive breast cancers, after that treatment of surgery, chemotherapy, or radiotherapy, depending on the situation, they have to continue a treatment with what we call adjuvant endocrine therapy, which is a long-term treatment that has the objective of reducing estrogen levels or to block estrogen receptors for at least 5 years, but now up to 10. And the objective of this treatment is to reduce the recurrence of breast cancer and, of course, to improve associated mortality and disease outcomes. Endocrine therapy in some countries is also used as a primary prevention in women at high risk for developing breast cancer. And so these women also have these side effects. And as Melinda was mentioning, vasomotor symptoms, which is also referred as hot flashes, is a very well-known and very common adverse reaction to endocrine therapy, which strongly impacts the quality of life and even treatment continuation. And I, as a medical doctor, I always like to see some data. So I bring you some numbers to help you also visualize how relevant is this situation. So Ashman did a large cohort study evaluating the early discontinuation and non-adherence, so women not taking the treatment correctly, in almost 9,000 women with early stage breast cancer, so similar to Cheryl's situation, over a 10-year period, and found that only around 49% of patients, of women, took this treatment for the full duration in the optimal schedule. So the majority was not compliant with the treatment. And this situation was even more impactful for younger women, where they have seen a higher risk of non-adherence. And of course, since this treatment is given with the objective of reducing the recurrence of disease, there were also some studies looking into the impact of this discontinuation. And indeed, the Canto study analyzed the serum levels of these treatments in order to really check whether the serum levels were aligned with a correct intake of the medication, and found that after a median of 2 years of follow-up, women who were not compliant with the treatment had a significantly shorter distant disease-free survival. So indeed, not having the treatment and not taking the treatment correctly for the needed amount of time does have an impact in the outcome and ultimately in recurrence of disease and survival. So as I mentioned, these women currently have no approved options. And this really highlights the need for new products, new treatments for these women so that they can continue to take their treatment and get the best possible care.
Thank you very much. And that is a very crucial point. So let's drill down a little bit deeper on the adverse impact that vasomotoric symptoms can have on treatment and therefore also on outcomes with Dr. Gilbert Donders. He's a practicing gynecologist who serves as professor at the University of Antwerp, heads the nonprofit clinical research organization Femicare, and was recently appointed president-elect of the International Society of Infectious Diseases in Obstetrics and Gynecology. Over to you, Dr. Donders. I think you're on mute, sir. Your microphone.
Okay, sorry. Thank you for the nice introduction, Melinda. As a person dealing with a lot of the side effects of women with breast cancer being treated with anti-hormonal therapy, I'm very glad that I got the forum for a few minutes to address a few of these issues. So the burden of hot flushes generally split off in 3 main categories. One category is what we all know, and that's the physical burden, which is not well known to the massive public. And I'm talking now about general patients, not only breast cancer patients, linking the moderate and severe hot flushes to an increased risk of cardiac infarction, of stroke, of morbus Alzheimer, and of an increased risk of death after hip fractures, which are all different items of your body that people don't seem to realize that they are linked to the severity of hot flushes. So that's one type of burden. Another burden, and that was mentioned before already, is also the financial burden, which we shouldn't underestimate. For hot flushes, people go and buy over-the-counter treatments in massive rates. I mean, they spend lots of money on suboptimal products that are claimed to be efficient, and they can get it for free on the internet or on the pharmacist visits. So don't forget also the multiple physician visits where they go and complain about different issues that are related to hot flushes, such as bad sleeping quality and so on. Hygienic care, I mean, people start sweating, their skin starts to change, they have an increased issue with maintenance of their body shape and fitness, which costs also a lot of money. And don't forget the loss of work productivity. I mean, people at work seem to, and there is data on that, seem to lose very often work opportunity because of these hot flushes. And then third, there is the social burden, and that's the one that we know best, because moderate and severe hot flushes, they are linked to an increased social incapacity. So at work, you're in a meeting, you start to get these hot flushes, you have to stop talking. I mean, it's just very embarrassing. It's very, very difficult to continue your work. And you see all these people staring at you while you are like sweating like hell and can't even proceed with the meeting. So there is also these decreased sleep quality issues. I mean, if you have hot flushes during the night, you have to remove all your sheets, you have to undress, you have to go and shower, get back to bed. it does severely influence your sleep quality. That, of course, makes you during the day not the same person because you're tired. You have a high uncontrollable emotionality, so you have these outbursts of emotion that you start shouting at your partner. He doesn't know why, and you feel sorry 5 minutes after. So it's something that we should not underestimate. And then there is the anxiety issues that some people don't seem to see, that lead to depression and sometimes even bad thoughts about staying alive. So this for all patients. In breast cancer patients in special, this all even becomes worse because they don't have a chance to treat themselves like it should be. I mean, there is the incapability of having normal hormone replacement because of their breast cancer, which is then even increased by the loss of sexual attractivity. I mean, you've been operated on your breast, it changes its form, some lose their breast, you have vaginal atrophy, you have to stop hormonal replacement therapy, which all are factors that life doesn't go easy for you. Then there is these, we didn't address this, but there is these worries about survival. I mean, you have a cancer, so that people tell you this is very severe and you have to be under control for the rest of your life. So this also makes your worries as a breast cancer patient even more severe. And then finally, which is said before, and I do agree with this is all increased by anti-hormonal therapy. This does induce all of these side effects, which makes it worse. On top of this, you go to your oncologist and the endocrinologist, and they just care about numbers, about survival. They don't care about quality of life in very many cases. So then people come to us as gynecologists, of people taking care of general life of women, and then we see, because of the strict seeing on hormone use, that we have to have something to help them. So what do we have? What do we have? We can't use hormones, so we have plant-derived pseudohormones, but the activity is no more than 15%. What does it mean, 15% above placebo? It means that you have, of the 7 hot flushes, now you have 6. That's 15%. So is that good? No, it's not good. It's very expensive. It doesn't work very well. Then there is people that get antidepressive therapy, but as you all agree with me, if you have hot flushes, you're not very well benefited with antidepressive therapy because that's not what you need. We need something more basic, and that's why I'm very happy that nowadays I've been involved in new clinical studies with new drugs coming, working on a non-hormonal level to reduce these hot flushes also for these women. So that's my contribution of this major problem that we have.
Very, very interesting indeed. Many thanks to you, Professor Donders, for reinforcing the message that there are treatment options out there, they're in the works, and that can have real benefits for women who are aware of them. So let's just make a very brief pause here, because I want to note that we have a worldwide audience following us right now. People from India, Costa Rica, Switzerland, Chile, Vietnam, Brazil, Germany, Mexico, Sweden, and many, many more. A very warm welcome and a lot of gratitude to the thousands who are joining us here for this discussion. Send us your questions. We're very, very eager to also pose your questions to our speakers. So do please post them here on this live stream, and we will then take them at the end of our session. And I'd like to just do now a second quick round amongst our speakers to talk a little bit more about the points that have been raised in regard to the systemic healthcare challenges associated with providing more options for women in dealing with both vasomotoric symptoms, hot flashes, as well as with conditions like dense breast tissue that can make supplemental imaging so beneficial. And I know it's a big request, but since I really want to get to those audience questions, please, dear participants, do keep your answers to under 3 minutes, if you'd be so kind. And now I'll go first to Cheryl and ask you to talk a little bit about whether you yourself experienced such vasomotoric symptoms. I know you didn't have chemotherapy, so perhaps you got off a little bit with milder effects. But I know that you're doing a lot of work with other patients in your advocacy activities. So maybe you can also tell us what they're experiencing. And when women are dealing with these symptoms, where do they go? Do they tend to rely on online forums, or are they going to their healthcare practitioners and experiencing knowledgeable interaction with them?
No, thank you. Yes, I did experience some, but I had minimal treatment, so I did get away with it in some ways of shape or form. After my radiotherapy treatment, yes, I was prescribed medication, induced my menopause. So, of course, my menstrual cycle periods, they stopped. I didn't miss those, I'll be honest, didn't miss those at all. But in all fairness, the main one was, as Professor Donders has said, the hot flushes during the day, and at night, the night sweats. They were quite annoying, but I found them just about tolerable, I guess. I'd retired from my profession as a teacher, so it was slightly easier. I wasn't having to have too much sleep every night. And I also put on a tiny bit of weight, so I had to be very careful and watch my diet and exercise. The other thing I did actually experience was vertigo, which I'd never experienced before, and I didn't know if that was associated. But other women who I speak with, they share their experiences, and unfortunately they had much more than I did. They had things like brain fog they talked about. They get muddled and forgetful and get very confused, and they couldn't concentrate and fuzzy-headed. Some reported vaginal dryness and loss of libido, and some experienced fatigue, others nausea too. So there seems to be a huge range of symptoms. Again, like I say, I didn't have many of those. In terms of turning to people, when I started to get these symptoms, I live in rural France and there are very few support networks around here locally. So I reached out, and I found that I had to reach out online to support groups. It was my only option. And it was really nice to be able to talk to other women about their breast cancer journeys, about their treatment, about their care, ask them questions, share our experiences and what they were going through. And that was opposed to talking to a healthcare professional who's a breast cancer expert, has breast cancer expertise, but they haven't had breast cancer. So yeah, I found that really useful, just online weekly meetups with people. Yes, indeed.
Thank you, Cheryl. Let me go over to Dr. Donders Gilbert, if I may, again, and ask you to talk about awareness and communication on both sides. So on the patient side, patients on endocrine therapy, do they generally disclose that they're experiencing these vasomotoric symptoms, or is there a kind of a taboo around anything related to apparent menopausal symptoms? And if there's some reluctance there, how well informed and aware are healthcare practitioners? Do they have sufficient awareness about this to really directly question patients in an effective way, or do they themselves need to become more aware?
Yeah, Melinda, thank you for that question. As you insinuate yourself already, there is some reluctance and there is some taboo about speaking about these things because it means you're getting old. I mean, it's a sign of deterioration of your body because of the hormones don't work anymore, whether it is induced by breast cancer therapy or it is natural. It's something women don't like. It doesn't make you prettier, it doesn't make you younger, it doesn't make you more efficient. So there's no good reason to be proud of these things. So that's maybe one reason why women not spontaneously start about this. Nobody wants to be complaining all the time. But we as physicians, and that is the crucial point, we need to ask. I mean, it doesn't make sense to let a woman come in your office and talk to her about surviving breast cancer and so on without addressing all these issues. You have to ask. You have to ask about sex life. You have to ask about hot flushes, ask about sleep quality, ask about anxiety and depressive feelings, and ask about this, and then you get an answer. mostly you get an answer. So people are not afraid to answer your questions, but you need to ask them. And concerning the awareness of doctors, I have to admit, sometimes I'm very surprised to see that even doctors with good training and clever people don't seem to open this discussion with their patients. And I have, in Belgium at least, an idea that people that are not fully professional with women, but see all types of patients, like GPs, very often are much more reluctant to address these issues and to open up this discussion than specialists that are focused on that. And even about therapy. I mean, if you talk, now I'm talking hormonal replacement therapy, where it is possible, some doctors are also very reluctant. And I don't understand this, because it makes your life not only less miserable, but you live longer if you give it the right indications. And if you have no contraindications, you can give these treatments. And still there is doctors that are opposed to this, and that they tell them not too long and don't do this, and and it's maybe not good for you and you could get cancer and so on and so on. And they just limit their view on what they're telling patients on just one item, which is not good. I mean, a woman is, I call it, a woman is not two breasts on feet. It's much more than that. You have to be open and discuss all of these items. And a lot of doctors, indeed, I must admit, could do this a little bit better, yes.
Thank you very much. Let me go over to Cecilia to get your take. Also, in regard to the impact of VMS, both on the women themselves, but on the healthcare system as a whole. And I'm thinking there, of course, about this potential for treatment discontinuation if women are experiencing symptoms so burdensome that they simply don't want to go on. So maybe you can talk a little bit about that.
Yeah, totally, Melinda. So indeed, menopausal symptoms are common, as we have been discussing, are long-lasting, are debilitating for some women, and they have a broad impact on women both physically and emotionally. As Professor Dondes was mentioning, this is much more complex situation than just talk about the progression of the disease or the cancer itself. It really implies an effect and an impact in multiple levels. So, of course, symptoms are responsible for higher healthcare costs, and we have data from the US that shows that women with vasomotor symptoms have around 120% higher healthcare utilization than women without VMS, controlled for the same situation. But of course, as Professor Dondes was mentioning, impaired work ability, increased absenteeism, all these aspects really sum up to the impact of the symptoms also in society. And very importantly, as we were mentioning as well, these symptoms can also be a reason for discontinuation of treatment, and then, of course, impact the breast cancer recurrence and disease outcome. And indeed, we see that, and it's interesting that we see that many women are not even open to their physicians and saying that they are not taking the treatment. So I think that the lack of dialogue is not only on diagnosing the symptoms itself, but also recognizing that there is a problem. And I know I have seen these patients in clinical practice myself. It's always very difficult for a doctor also to ask about symptoms when we don't have anything to offer. So we can try the half full glass option by saying, well, if you have these symptoms, it's a good sign. It means that the treatment is working and that you will have a better outcome. But it's heartbreaking for healthcare providers not to be able to really prescribe or do something that really will change the life of their patients. So I think that this is a complex situation where we need to intervene in multiple aspects: awareness within women and society, awareness within healthcare providers, but also very importantly, really advancing the science and providing more options.
Thank you so much. And staying with the topic of challenges around communication and awareness, let me return to Hassan and Elisa. But before I pose a question to them, let me just tell everybody in the audience, we are so eager to hear from you. So please do send us your questions or short comments on our Q&A function here on the live stream. So clearly greater awareness of and attention to vasomotoric symptoms could improve outcomes for individual patients, as well as the effectiveness of the healthcare system as a whole. And that seems to be true for early screening as well. So, Hassan, if I may begin with you, how can we ensure that more patients have access to these procedures when the circumstances indicate that they're needed? And what benefits would you expect that to have, not only for the women, the particular women involved, but also for the overall healthcare system?
I mean, it's a very good question. How we ensure it's really a very important question, because I guess this is a very a shared responsibility to provide access to these modalities for early detection of breast cancer to women. So it's a responsibility of healthcare professionals, patients, and also healthcare organizations or even governments, because this is a very important issue to provide women with extremely dense breast another modality to help them in the diagnosis of breast cancer. And breast cancer, just to let you know, like, because we since I worked on breast cancer, in any discussion, you find someone either impacted with breast cancer or a relative or a friend is really impacted. So you can see it everywhere. It's not a disease that you, or a cancer, it's a leading cancer worldwide. So the early detection is very important. It's not an issue that we say, and early detection is completely different from delayed. So with early detection, you can have a small operation and then you can return to the normal population having nothing. Delayed, this is something else, right? You will go to a very intense treatment and follow up, and the impact is huge on the patient. So to return to your question, this is a very shared responsibility. Like, from our side, we try as much as we can to support either patient organization or medical societies to provide more education, more information, supporting even research to make sure that the evidence is there. And when we look in particular for extremely dense breast, there is a clear evidence about the role of supplemental screening. So it's a shared responsibility. And when we have the education of women to understand that they have a dense breast, this is very important. And this is a responsibility maybe of all of us to have women understanding the risk. You have either the risk or even the density of the breast. And then the responsibility of the healthcare professionals to communicate this. And maybe together they try to find an access to a supplemental imaging modality to help them in the early detection. So it's a very huge responsibility and a shared one. We should all do whatever we can to help women access to supplemental screening. And we always say it could be very simple. So first, we have to make sure women do mammography. This is very important. And second, they have to understand the risk. So they have to understand either they have a risk or maybe the breast density issue. And third, they talk openly about that. I am the woman to inform the physician that I have a dense breast. I know that I will benefit more from supplemental imaging. How can we access together? And we all try to provide this evidence to everyone who can provide access to women to make it available. So I guess it's a very shared responsibility. And the impact on I would like first to say the impact on women, because the impact on women is very important before even the healthcare systems.
Thank you very much. Clearly it's crucial to, especially for women with dense breast tissue, to be looking at these supplemental imaging options, Elisa. And you told us about the great advantages offered by magnetic resonance imaging. But of course, many of us think that also high costs tend to be associated with MRI. So what do the cost-benefit analyses tell us about how that balances out? And do you see potential for MRI to become the standard screening for certain groups of patients at least, or do we see a cost-benefit analysis that essentially wouldn't justify that?
Thanks, Melinda, for the question. This cost effectiveness analysis aspect is extremely important indeed. So let's start right from there. And just to clarify, what we mean is that we are comparing now the cost of implementing a potential screening program using MRI versus the benefit that it could bring. So potentially detecting cancers earlier. And the cost of MRI is mainly driven by the cost of the examination itself. And that's really where the efforts of trying to shorten the exam come from? Because if we can make the acquisition of the images shorter, we can scan more women, so we can increase the throughput, and this lower the overall costs. And if we now look at the other side of the equation, so the benefits, we are talking about detecting cancers earlier, which could mean to potentially save lives. And there is data that support this. So there are studies that have shown that if you implement a screening program based on MR, having an MR every 2 to 4 years, for example, in a population like women with dense breasts, this is indeed cost efficient. And as you said, this supplemental screening is not meant to be applied for every woman. We are really talking about a subset of women where we know that the benefits outweigh the costs. And now on the second part of your question on whether I believe there is potential, I can say that yes, I do believe there is potential for MR to become standard for screening. Evidence is there. It's, as a matter of fact, it's already recommended, and it's becoming part of the guidelines as well. And lastly, how we can make MR for breast cancer screening a reality? Well, talking from a technology provider perspective, I can't stress this enough. Making the examination shorter, more standardized, but also making the exam more convenient for women, because this might increase the willingness to then adopt this technique. So we talk comfort, we talk atmosphere, and we talk education.
Thank you so much. And let us now go straight to audience questions. And because we ended there with MRIs, let me start out with a question about MRIs, and I'll direct this to Elisa also, if I may. What would you say to women who might be scared of having an MRI exam because of the closed space, because of the loud noise? What's your answer, Elisa? You're on mute at the moment, Elisa?
Yes.
Oops. Oh, there she is.
Sorry.
Okay. Yeah, no worries.
Well, first of all, I would say that this is a completely normal perception. I know that this is a very common feeling that people might experience some anxiety. And I think that even though this procedure might be a bit uncomfortable, it's important to know that, first of all, it does not have any harmful radiation, so you are safe in that sense. The fact that the breast is not compressed is also, I think, make it a little bit less painful than what you might think. And can't stress this enough. Again, we do our best to really make the examination as short or as fast as possible. So, to stay within the 10 minutes in a potential screening setting. And most of all, I believe reminding yourself of what you could potentially gain by overcoming this fear makes it worth it.
Thank you very much. And then a question, if I may, to Hassan. This comes from Darlene Honey, and it's a little bit technical, but I'll just put it out there and let Hassan take over. Lobular breast cancer patients have difficulties getting diagnosis for primary, and meds often have a different pattern with lobular, i.e. gastro, gyno, skin. How can we improve knowledge for non-breast clinicians that may see but not recognize a lobular mets presentation as often no lump?
I mean, this is a very good question. I would say it's mainly about education, right? Because, what we're trying to do is to provide this kind of support to medical societies to provide more education, not only to radiologists or to treating physicians, but also to the healthcare community as a general. So it's mainly about education, right? Because this is a very technical, it could vary from a physician to another one. So it's about education, and we're doing this as much as we can from their perspective.
Thank you very much. And in regard to awareness and education, also a question directly to Cheryl. And the question is this: how can we reach groups that historically are less likely to receive cancer screening? Do you have any examples of successful campaigns?
There are. I mean, it differs all around the world, and women don't have this awareness, don't have access to breast cancer charities. There are so many varied activities that do happen. There are events, live events. There are in terms of runs and walks and things like that. And I think there are a lot of educational initiatives that are out there trying to get the message across to women. And, you know, even coffee mornings, there's one in the UK where there's a coffee morning every year and they're raising awareness about cancer. So, yeah, there are various campaigns and initiatives, and it's to do with developing patient tools as well. And Elisa mentioned it and Hassan mentioned it, education. It's just key. It's just education for patients, for the public, in terms of just raising awareness and educating patients, but also educating healthcare professionals too. Yes.
Thank you very much. And staying now with diagnosis and screening, and a question for Dr. Dondas. Is there a trend toward younger women being diagnosed? Are you seeing that?
There is, for two reasons. First of all, there is a trend of having more breast cancer in younger women than years ago. And secondly, because we tend to have attention for this at an earlier age than we used to. So in the older times, we would start screening at 50 or 50 plus, but nowadays, you see now in the US already screening at 40. I already did this for a long time at 45, between 40 and 45, a first examination, and then after 45 at a regular base. So you see that more and more coming, so that we have opportunities to diagnose breast cancer in younger women earlier. And that of course saves lives. I think this is the way to go. And certainly if we start using more MRIs so that there is no irradiation effects on younger breast tissues, it will also help. So the answer is yes.
Thank you very much. And if I may stay with you, Dr. Dondas, and switch tracks now to vasomotoric symptoms. You talked about the fact that patients sometimes don't want to disclose these symptoms, that there is reluctance to talk about them. So if patients don't share that during their consultations, how can we address those barriers? You talked about the importance of healthcare practitioners becoming more aware, but specifically, what would be your message on how we can address the barriers that patients, and apparently also some practitioners, from what you said before, seem to feel? And this is also an audience question, sorry.
Yes, well, the problem is that these women, they are squeezed between the oncologist and the other doctors, and they don't dare to complain all the time, because they will then say and answer, but listen, you're still alive and you're still doing fine and you will survive. So what are you complaining about? So they don't dare very often, even for vaginal atrophy. I see that very often they're so much afraid to address these issues that they very often don't spontaneously start to talk about them. So it is really our duty, our task as a physician, to address these issues, to open up the discussion. And people are so thankful for that if you do so, because they came with these worries and these issues, but if you don't ask and they go out and then nothing happened again, so they're dissatisfied. So people are very open to address these, but we as physicians have to open the discussion. I don't know why it's not done. I think because it's time consuming, perhaps because it requires some skills to without any shame discuss these issues. But I think we need to teach young people, and that's what we do every day, to open up these questions and take time for that for patients. I must also admit, as Cecilia told us before, that we don't always have a lot to offer, and that is also an issue. I mean, if you ask about complaints and then you say, but I can't offer you much, that is, of course, as a physician, a very dreadful thing to do. So you want to ask a question for which you have an answer. And I hope in the future we will have more answers. But nowadays, this is a little bit a failure, that we can't really give them a good answer of what to do if they have these complaints.
Thank you very much. And let me go to Cecilia now to talk a little bit more about VMS and comorbidities. We heard from Dr. Dondas about some of the other burdensome problems and health endangering problems associated with hot flashes. Can you talk a little bit more about that from your point of view? Again, this is a question coming from the audience.
Yeah, totally, Melinda. This is really an interesting topic. And here science is actually advancing. So before it was thought that the comorbidities associated with hot flashes were only dependent on low levels of estrogen, so that this would then cause increased risk for cardiovascular disease. However, a recent publication and a recent study that was published by Rebecca Thurston done in the SWAN cohort. So this is a cohort of more than 3,000 women, which are being followed for 20 years. And we have been learning a lot around menopause and midlife health with the SWAN cohort. And they reported that women with persistent vasomotor symptoms had 50 to 77% increased risk of future cardiovascular disease, independent of the treatment and independent of the estrogen levels. So indeed, VMS or hot flashes may represent a novel female-specific cardiovascular disease risk factor. And then, of course, as Professor Donders also mentioned, there is the impact on sleep. And we know that poor sleep or sleep disturbance is also associated with cardiovascular disease, with neurologic conditions as well, impacting cognition as well, and also impact on mood. It is very common to see and to hear women with menopausal symptoms complaining about mood problems. Depression is also more likely in this group. So it is important to be aware of the broad impact of hot flashes and of menopause, because menopause is much more than just a hot flash. And this is really important for women and physicians to be aware of.
Thank you very much. Then I have a couple of questions coming in from Mehran Bazagari. And the first one is this, and I'll direct it to Dr. Dondas. Are there specific biomarkers or predictive factors that can help identify breast cancer patients at a higher risk of experiencing VMS during their therapies?
That's a very good question, and I wish we had, because up to my awareness, we don't. In non-breast cancer patients, what you could do is measure estrogens, oestrone, estradiol, and in the serum to see if they're very low. You can predict more often severe hot flushes to come. But in breast cancer patients on anti-hormonal therapy, you suppose that all of them have such a high level depression of their estrogen levels that you can't measure anything in none of them, because that's the aim of the medication. So in these women in particular, I'm not aware of any biomarker that could help us to predict which person or who will, yes or no, develop hot or severe menopausal hot flushes or not. So the answer is, I think, as far as I know, there is no such biomarker present to predict this.
Thank you very much. Our clock is ticking down, but I'm going to try to squeeze a few more questions in. Another one from the same audience member, Mehran Bazagari, direct to Elisa. What are the key challenges in achieving equitable access to mammography, and how can health policy and market access strategies address these challenges? Briefly, if you would, Elisa.
Yeah, thank you for the question. So the issue of accessibility is something that we all care so much about, and it's such an important topic, not only for mammography, but for MR as well. So now I can speak for, the MR part. With MR, it is a very it's quite an expensive technology, but what we are trying to do as a technology provider is trying to make this more accessible and available, not only in every country, basically. So trying to really expand the reach of these technologies so that it can be available for everyone everywhere. So yeah, if someone else in the panel wants to comment on the mammography aspect.
Raise your finger if you do, please. Anybody else want to add a comment on that point? Doesn't look like it right now, and that's probably a good thing because our clock is almost up, and I just want to go back to Cheryl with one last very quick question, and that is whether awareness of the risk factors and the perceived importance of screening differs across different subpopulations and across different regions. And if so, what can we do to raise awareness?
Yes, I think so. I mean, basically, guidelines on breast screening, they around the world, they differ. So in some countries they start at a certain different age, and there's some they stop at a different age. And in terms of, regardless of breast screening guidelines and routine organised screening, the key point is I will keep going back to education, because my role, I see it as, is whilst we're waiting for MRI, whilst we're waiting for different modalities to be introduced for certain types of breast type, if a mammogram alone on dense breast tissue is not enough and supplemental screening is required, then the only thing that we can do in the meantime is to educate, and that's to educate patients, women, healthcare professionals too, scientists, everybody. If we actually use that education to try and get everyone to collaborate and have a conversation, that could possibly, education is a very, very powerful tool, and it could actually improve outcomes. Yes.
Thank you so much. Fitting closing words for this event in conjunction with Breast Cancer Awareness Month. This does wrap up our LinkedIn Live event. We got some excellent questions there. I'm sorry to say we didn't get to every single one, but thank you so much to our audience for sending in these very, very perceptive questions. And I think we can see on those questions, with those questions, that we have 1,000 people joining us from over 30 different countries. It is just a great honor to have had all of you with us. Our topic has been advancing outcomes for breast cancer patients. I think we've learned a lot about both screening and treatment options that are available, and about which many of us have not been aware. So thank you so much to all of our speakers for sharing their knowledge and their insights with us. It has been a very valuable opportunity to exchange views on both supplemental screening and on vasomotoric symptoms, and the fact that actually something can be done about them if we're willing to speak openly with others, including practitioners and other women. So, dear audience, in case you missed anything and you'd like to hear our discussion again, you will find a recording on LinkedIn as well as on YouTube. We will post the link on our LinkedIn event page. I'd like to thank all of Bayer's team for making our discussion possible. And once again, special thanks to all of you following us online. Ladies and gentlemen, we are so grateful for your attention and your participation. I wish everyone a great afternoon or evening. Stay healthy. Goodbye.